Good evening, everybody. Wow, that's great. My students don't do that. Okay. We are so glad that you're here tonight. I hope you've seen the flyers. I hope you've gotten a lot of the emails we've sent out, and we've got a lot of help from other faculty to help spread the word about this event. We're calling this the Careers in Aging, the Continuum of Care, as a first attempt to really look at opportunities for work and practice related to aging services and what that really means across a broad range of settings and professional roles. We drew upon our contacts to bring 5 people here tonight who each have very different responsibilities and different types of practice. Some working independently as consultants. You saw some of our speakers are care managers. Other people are directors and administrators. And they're going to talk to you about what it means to provide care. I think what we're really focused on tonight is community-based care models in different settings where all of these professionals are serving the needs of older adults who are trying to be independent and still in the community. This came together, I would say, relatively quickly here at York. If some of you, I'm sure, know, we have PA students here tonight, physician assistant. We might have some nursing students. We have gerontology students here. We have a gerontology major here at York College. And we have also a minor in gerontology. And this whole event tonight, the idea for this started about a year ago. We have a new dean here for the School of Health and Behavioral Sciences. And there was a research day organized for faculty trying to bring professors together among common interests. And it was a very nice surprise for myself and Professor Lane, my colleague in gerontology, to discover that there are other professors here interested in aging in many different disciplines and departments. So gerontology at York College is a very interdisciplinary and interdepartmental degree. So we first met a year ago and started to realize we had common interests and we could start collaborating. And this is our first attempt, and I'll tell you a little bit more about that in a minute. But I really wanted to thank all of the people in our professional colleagues, other professors here, and administrators and the dean herself for making all of this possible. All of this, again, happened very quickly over the summer, putting this idea together. And we called upon the chair of our department, Dr. Julichukwu, very quickly at the last minute to say, we have to do this idea and you have to support it. And we're very lucky that he did. So I wanted to thank Dr. Julichukwu first. He's here tonight. It takes the signature. It takes the signature of department chairperson to get things moving here at York College. So that was the first step, and it happened very quickly. We also started to get input from other professors here. Linda Barley, she's not here tonight, but she was really responsible for starting gerontology here at York College. We should thank her. And then this went right away. This was a school-funded, it's a college-funded event, the Auxiliary Fund. This proposal went right to Dean Clark, the new Dean of School of Health and Behavioral Sciences, and she liked this idea right away and wanted to help as much as possible. So that was the next step. I really wanted to thank Dean Clark. Unfortunately, she could not be here tonight. She's in Philadelphia on other business for the college. And her assistant, she has a terrific administrative assistant, Mr. Batista, who really helped everything move along very quickly, including making sure we almost did not have food tonight. So you might want to thank him most of all. So, as I mentioned, at this research day only 1 year ago, that's not really a long time, a bunch of us sat together at a table, professors, and realized we all were interested in research and service and practice around aging and gerontology. And at York College, to be a gero major, you have to take classes in psychology, social work, and then electives in political science and history, sociology. And some of you may be taking classes with some of these other professors, and I wanted to acknowledge them and let you know that we're hoping to do a lot more collaborative events with them in the future. So from psychology is Professor Deborah Meyerowitz, social work, Francisco Villegas, OT, Lillian Kaplan and Professor Beverly Horowitz are great supporters. From nursing, Renee Wright, Emily Davidson, Professor John Grafeo. From PA, Emily Davidson is the chair of health professions. And we also have faculty who teach these Gero classes. Many of them are electives for our students. Katria Mokru in psychology, William Diwali, anthropology, Robin Harper, political science, Professor Charles in our own department, who teaches a Gero class. And again, Professor Linda Barley and Dr. Ujuluchukwu both teach classes. All of these people are involved in making it possible for students here to get a degree in gerontology. So, a year ago we all met, discovered we're interested in aging. Professor Grafeo invited Professor Lane, I don't know if she wants to stand up, I'm sure you know who she is, but she's injured her she's injured her foot, she cannot stand. Professor Grafeo invited myself and Professor Lane to come and speak to the PA students in an event very similar to this, and to talk about the role of the PA and the primary care provider in community-based care and holistic care for older patients, for geriatric patients. And we had a terrific time, and it really made us believe that we could start doing more of this, and we could probably do this every semester if we could pull it together. So I'm very thankful to Professor Grafeo and Emily Davidson for inviting us to come out of our building, go into another building, into another department, and meet your students, which we don't always have a chance to do. So thank you to them. And the last statement I wanted to make is we are also starting to do outreach to the community colleges at CUNY, where many of our Gero students actually transfer in or transfer up from other, the two-year colleges in CUNY getting associate's degrees. And we're getting tremendous support and interest from the community colleges who realize that getting a bachelor's degree in gerontology in the CUNY system often requires doing an associate's degree first at one institution and then coming here to finish and getting the bachelor's. So we are really trying to improve the transfer process for students to help them get a solid foundation at the associate level, and then when they come here, not have to spend too much extra time on their way toward getting their bachelor's. So I will keep you all posted that we're getting terrific response from faculty at Hostos Community College, Kingsborough Community College, Borough of Manhattan Community College, and LaGuardia. And I was told some of the students from Kingsborough might be here tonight. Did you make it? Okay, traffic, subway. And I have news for Professor Grafeo and Lane that the department at Kingsborough has invited us to speak in the spring and do an event like this at Kingsborough Community College. So I'll keep you posted. With that said, I thought what would be interesting to start the evening is we're going to show you a short video from the Association for Gerontology in Higher Education. It's about 8 to 10 minutes long, to show you some of I'd say, what it takes to pursue a career in aging and what that might mean. And I just want to break the ice a little bit to show you what the different levels of care and levels of involvement can be. Either one-on-one direct work with an individual, or some of the interviews you'll see are people who talk about doing work as directors, planners, and administrators. And then as soon as the video is done, you'll, I think, recognize some of the roles of our speakers and mentioned in the film, and we'll introduce each of our speakers. Okay? So, I'm sorry, you guys. We have a big screen, unfortunately. We're going to use the screen up here. You just hit the GSA.
a growing need for people who work in the field of aging. Some work directly with older persons in a wide variety of programs and services in the community. Others work on behalf of older persons in areas such as research, advocacy, and teaching about aging. The goal in both is to increase the quality of our lives as we age.
I represent people with Alzheimer's disease and their families. And we talk to Congress and try to affect the laws of this country to help people.
I work for the Educational Organization for United Latin Americans, Spanish Senior Center.
I'm involved in looking at older adults and working with businesses to help them shape products and services to meet the needs of seniors.
I'm the Director of Activities and Community Relations.
I'm the Director of the Center of Aging, Health, and Humanities.
I am the Director of Marketing and Admissions.
It's in many ways a brand new field. There has long been research on aging, but never to the magnitude and intensity that's going on now.
When you're working in the area of advocacy and policy, you're able to make a difference that affects not just the lives of one or two people, which is very important, but can affect the lives of literally millions of people. And I think that's exciting.
One resident who's both blind and deaf, so the only link she has to the world is through touch, and she just folds into and you touch her face, and you just know you're making a difference, and it's a wonderful feeling.
Once you put your foot in, you're stuck right in, because the aging population are just a wonderful group of people who are very loving, very caring. You learn so much from them. And although you're supposed to be the one giving services to them, you're getting so much more from them.
The demographics, this growing aging population is only going to get bigger. Population is only going to increase. The needs are going to get more and more diverse. So I feel I was fortunate to be at the beginning of this, but I suspect it will just continue to get bigger and bigger.
Geriatrics, physicians, nurses, we have a range of different health professionals, from dentists to social workers, physical therapists. You name the field, all of these areas are catching the excitement of looking at issues of aging.
This is my first stop. I've been here about a year.
I'm the son of a minister, so I have this problem that I have to work to make the world a better place. It was a perfect place for me to kind of blend my interest in academics and research and policy with this kind of need for social change. The key to being a good advocate is being passionate about what you're advocating for.
We had a resident here who was over 100 years old, and she was a canteen girl in World War I. And that's an experience that I got through her that I would never gotten through history books.
There's just an enormous range of opportunity.
I'm actually getting ready to go through an administrator training program to actually try to get my license.
I see more and more young people being hired by companies, especially in marketing and PR kinds of roles.
Whether you want to go in research, whether you want to work one-on-one with the senior, or whether you want to work behind the scenes and make the difference from that end, as a lobbyist or as a policy maker, there are just great job opportunities.
When I go home at night, I feel satisfied. I feel like I've made a difference. I feel like there's an endless need out there, and I'm making a difference.
One of the most recent issues of U.S. News and World Report, for example, said geriatrics is the field of the future.
I love my job. I get excited because of the possibilities, and anything I do is new. That's the value of my job. Anything I do or start is something that hasn't been done before, because that's how new the field is in terms of public-private partnerships, working with business. So each day I sort of have a choice of which thing I'll tackle, knowing that it will make a difference in someone's life. And that's very satisfying, very rewarding, and it's more than just a paycheck.
Well, it's a real
nursing home when I was a teenager and enjoyed it. And then when I was in college, I had a professor who encouraged me to take more classes to learn more about the field and to learn about the aging process.
I have a PhD in the sociology of aging.
My background is association management, public relations and marketing for associations. So I'm a cause kind of person. I like to picket and march and protest. And so, but I like to do PR and flashy things to get attention.
Many of my friends thought I was nuts to want to pursue a gerontology field. So when I went out to look and see what was involved in gerontology, I realized that it's really an interdisciplinary field.
Went to the medical school and training in psychiatry for becoming a gerontologist, a geriatric psychiatrist.
Go to volunteer. If you really like this job and you want to come and that's what you do.
I did 5 different internships between undergraduate and graduate school.
In senior housing now, tremendous growth opportunities. In healthcare, tremendous growth opportunities.
If you choose a career in aging that you learn later is not right for you, you can easily change your focus. You could go from marketing to activities. You could go from activities to administration.
You have to be patient. Sometimes it takes years to move even the smallest issue. But if you don't give up, you can see the fruits of your rewards, and it's great.
It's never been a better time than now to get into the field of aging.
Is the field of aging a possible career choice for you? If you're interested in improving the lives of older people and our society as a whole, career opportunities in the field of aging are waiting for you.
I'm telling the young people, go for it.
They need to be kind and considerate.
I think they need to like people, do the right thing, go and find a job.
Okay. Thank you so much, Amen. So this, I want to tell you, since this film was made, which was a few years ago, it's important to realize that all of you are right now working and studying at an important historical turning point. And I'm not going to go into a lot of the statistics and demographics, but I just wanted to mention, if you're wondering if there's going to be a need for you and a need to follow the advice in this film, we would say definitely yes. Here's a few little items I thought might get your attention. The World Health Organization has now reported that in 2015, in terms of the global population, there will be more people over the age of 65 than there will be children under the age of 5. We just are making a switch that will continue that gap will continue to grow after the next 3 years. Life expectancy has gone up again in this country. We just added another year in the past 2 years. We're now up to 80 for both men and women. Very close. And I'm sure all of you, if you're studying gerontology or in healthcare, you've heard of baby boomers, right? Yeah. Those are the 85 million people in this country who were born between 1946 and 64. So in 2011, something very important happened just last year. The front of that wave, those 85 million people, all are starting to turn 65. And so you should know why 65 is such an important age, right? In terms of social policy and funding. What we now know is, starting last year, 10,000 people a day are turning age 65 in this country. That's just the start of, quote, the older adult population. We now know that by 2040, there are going to be 15 million people in the US over the age of 85. And that segment of the population has been doubling every 20 years. So that's going to continue to climb, exponential growth. So there's a tremendous need if we just look at the demographics. I think what's wonderful about our panel of speakers tonight is they will tell you about what individuals need, not just the 85 million people out there, but the range of individual needs that all of them are committed to serving with their clients. So, I know their names are on the flyer. I hope you've gotten intrigued by some of their titles. I just wanted to introduce them tonight. We have, this is Ms. Nina Dobris from the Senior Umbrella Network of Queens. On the left. Mr. Robert Hofman, who, he will tell you what it means to be a geriatric personal trainer and also care manager. Ms. Stephanie Zevon from the Jamaica Service Program for Older Adults. We have Mr. Francisco Diaz, who is a geriatric nurse practitioner from the NYU Medical Center ElderCare Program. And Ms. Sherba Austin from Rochdale Village here in Queens, but she director of what we call the Naturally Occurring Retirement Community Services. So what we would like to do is want to give each person a chance to introduce themselves, tell you who they are and what it is that they do, if you're not familiar with these titles and positions. And I think we're just going to start with Ms. Dobris, if that's all right. I'll check the volume, but it is turned up.
Good evening, everybody, and thank you so much for coming here today. Really appreciate that there are so many faces out here, because the field of aging, as you've seen in the video, is growing exponentially. And personally, I have been in the field of aging for over 20 years as a social worker. I started in geriatrics just by chance. It found me rather than me finding it. I've worked, well, from the beginning I got a bachelor's degree, and then I got a master's degree in social work at Fordham University. Okay, and if anybody is interested in being a social worker, I strongly recommend that you at least get a master's degree. Okay. In addition to that, I also worked in nursing homes. I've worked in home care. I worked in hospitals in a variety of different areas. I've been out in the field. I've went to people's homes. I've helped them with Medicaid applications and other entitlements. I've done creative psychosocials in the nursing homes. And currently, I work for North Shore Long Island Jewish Medical Center as a geriatric care manager, and the name of my program is called Circle of Care. We are a fully owned and operated division of the home care network at North Shore LJ. And what I do is something that I love tremendously. Part of my job in this particular instance is marketing. I go out and I talk to professionals, and that's where I came in contact with York College, and that's how they know me from the Senior Umbrella Network. So there might be a little confusion. The Senior Umbrella Network is a networking organization that I belong to as in a way to help market my program. But I am an employee of North Shore LIJ. And what I do is I go out and provide evaluations for seniors and disabled persons in the community. It's actually quite free of charge. And what we do is we service clients everywhere from Suffolk County all the way to Staten Island. And I sit down with the clients and their families, and I try to help put things into perspective for them. I help them. Normally, they are quite overwhelmed with navigating through the healthcare maze. I have a lot of experience, as I described to you, in that area. So what I can do for them is try to help them put together a plan of care that's most appropriate for their needs. For example, the types of things that I help people with is to organize doctor's appointments, help them find the appropriate physicians. I help them put home care services into their homes at different levels of care. I can get construction people to come in and rehab their homes for handicap accessibility. I can help them pay their bills. I have referrals for all different kinds of things, and I actually like to consider myself a rent-a-daughter. So most of my clients don't have any family member that lives nearby, and if they do, they're too busy or unable to handle the pressures of taking care of a senior that lives in the community. I go with them to the doctor appointments, I make sure their pharmacy is taken care of, and I report back to the family members who normally live out of town. So those are the kind of things that I do as a geriatric care manager. And later on, I'm sure maybe some of you might have some more questions about what that is, and I'll be more than happy to answer any further questions.
Hi, my name is Rob. I'm also a geriatric care manager, so Nina gave already a good explanation what that all entails, but also besides that, I'm also a exercise specialist for the elderly. A little bit about my background, I'm a psychologist. I was a teacher and a therapist, but it was all in Holland. And then I had the opportunity to come to the States, and especially New York. I was there once and I thought, oh, I need to live here. And I had the opportunity to get into the fields, the care management field. In '96, I got a job there and as a care manager, and it gave me a work permit and eventually my green card. So that is actually how I got into the field. More like, okay, this is a way to get into the country. But I really liked the work very much. I'm also a very physical person. I ran, I do all kinds of stuff, and also in therapy, I use physical component to therapy, psychotherapy. And in 2000, I added to the care management qualifications I had already a health and fitness certification and an exercise specialist for the elderly certification through the American College of Sports Medicine. And that worked out as a great combination as a care manager and as a trainer for the elderly. I wear two hats, so to speak. Sometimes I wear them both at the same time. Sometimes I have the hat on as a care manager, sometimes the hat as a trainer. I come in as a care manager, I see that a client can profit from some exercise or activities besides physical therapy. That's a little different. I'll explain what that is. Or I come in as a trainer and see that other things needs to be done like a care manager. So then I switch to that role, or I combine both roles. So that's a little bit about my background and what I do at the moment. I work for a big corporation in the care management field, that's SeniorBridge. I work part-time for that corporation. It was actually the SeniorBridge that bought the little company I started working on. They bought it up, so I went to SeniorBridge. It's part of the package from the buyout. And I stayed with them part-time. I have my own company, Second Wind, I call it. And that is indeed both care management and fitness. And so I do different things. I do groups also in community centers. I teach Tai Chi, another very important way of doing things in terms of preventing falls and balance. So, well, I think that's it for now. So later on, if there are questions, please ask.
Good evening. I work at the other end of the spectrum, which is in the community-based, not-for-profit sector. A lot of you, if you go into geriatrics, will probably end up in this area because there is a great need there. What we do is provide day programs, congregate socialization, a congregate hot meal, transportation, access to services such as case assistance, HIV serving this community for 4 years. We have 3 senior centers in Jamaica and Southeast Queens. We do everything from medical appointments for older adults, taking them to see their doctor, to we pick them up, bring them in for socialization, for exercise, for case assistance, crisis intervention, safety programs. I mentioned our HIV program. When the first speaker was speaking, I realized I was thinking in my head, and I realized that I've been in the field 17 years, and I don't know how that's possible, because I'm still 25. But, you know, I started also at the community-based, you know, walk-in crisis intervention type. You really, to be in the field, you just kind of build yourself up. And I know everyone talks a little bit about their backgrounds. I also got my BSW. I fell into social work. I used to like to help people. Went to school, didn't really know what I was going to do. I thought I was going to be a teacher because I liked to help, and then I realized I didn't really like kids. So fell into social work and fell into geriatrics because I said, don't put me with old people. They stink, they complain, every stereotypical thing you would say about a senior citizen, I said to my field placement person. So guess where I was placed? Geriatrics. And I fell in love with it. So after that, I worked a little bit, I went back to school and also got my master's in social work, and I got it from Hunter College. Great program. Yeah, oh,
New York.
Yep. Did the 1-year residency program. The most important thing I would say is to get work experience. I think the video hit it on the head, which is volunteer, work in geriatrics, any which way you can. Each experience just builds the foundation and strengthens what you can do in the field. I've put my hand in every pot, including working on the governmental side at one point in time. I went and worked for the New York City Department for the Aging for a couple of years. And from that experience, I learned that wasn't for me. I wasn't meant to be a bureaucrat. I was meant to be in the community working. So that's a little bit of what we do, and I'm sure there'll be a lot more questions. Thank you.
Good evening. My name is Francisco Diaz. I am a nurse practitioner in both adult health and gerontology. I'm certified as such in both, but currently practice on only gerontology. And I've been doing that essentially for about 8 years or so. I'm Dominican, and in my culture, as probably in a lot of countries' culture, our elders are part of our life, everyday life. I grew up surrounded by older people, aunts and grandmas and what have you. So I had a sort of, by experience, understanding of them. When I came to the United States, I noticed how older people live here quite different. Somewhat more independent, and they travel on their own, they do their things. But also they end up alone, or they end up, in times of crisis, facing it by themselves. I was originally trained as a physician in the Dominican Republic, and when I came here after years of doing something else that I wanted to try other kinds of work, I got a call again to be in the medical field. And then I discovered that you could be something called nurse practitioner that is almost like a physician, and I thought after I explored the role, I realized that it's actually even better. And so I've been working mostly in the out or ambulatory field, which is meaning primary care in a practice. One of the things that gerontology or geriatrics has is that there is a diversity of areas where you could work. And when it comes to nursing, you can do long-term care nursing, which could be a nursing home, could be an assisted living facility, could be an independent living facility, could be at a NORC, could be in a van, could be in, you name it, it's possible to practice. Could be doing house calls too. It is a work that I consider a bit challenging. I face all gender, race, age, they're all different, and you cannot treat them the same way, and I like that because it keeps me active. One of the things in nursing also that I like is that you have to be a little bit of everything. You have to be able to do everything, from a little bit of social work, a little bit of advocacy, a little bit of accounting, because medications cost, and you have to know how you can help your patients to save their money. You have to be a little bit of a doctor, you have to give medication, you have to know, you have to teach them, you have to teach the family, you have to teach the cab driver, the people on the counter in the store, because you have to, when you're not advocating by your patient, you're advocating by somebody else's patient or somebody else's family. It's a booming field, supposedly. I said supposedly because then although the need is there is not, the numbers of people applying to gerontology is not growing. And there is something that I hope that these meetings like this do is to increase the numbers of people who are doing not just gerontology per se, but to apply gerontology, whether it's nursing, social work, or even medicine. Thank you.
My name is Sherba, and I'm the director of the Rochdale Village NORC program. That's the Naturally Occurring Retirement Community. The concept of the NORC program is you put some services or you put some social services into an area in the community where senior residents can benefit. Our seniors, unlike Professor Alex seniors, start at 65, we start at 60. So seniors are, people are considered seniors at age 60, okay, in our field from the Department for the Aging. So yeah, we have a lot of younger people who are qualified as seniors if you turn 60. And we service them in the community. It is a community-based program, and it's a helpful program in the community where we live to encourage our people to continue to live longer by providing them with the services that will benefit them so that they can stay in their community and live healthy and productive lives. I started off, I'm a graduate of Lehman College for my BSW, and then I went on to New York University for my master's degree. I am a licensed clinical social worker, and I supervise 7 employees at my program. So I'm not going to say I do a whole lot, we do a whole lot over there by providing case management, health and wellness programs, activities, and if you tap into each one of the speakers, we do a little bit of each, at my program. So it's a comprehensive program to service the seniors in the community.
So thank you so much. Jess, I thought it would be useful to recap for the students. Some of you had mentioned already kind of how you got here, your degrees. I just wanted people to hear again. We're going to ask you, some of you said you fell into the field, and we're wondering how did you get to your current role? You're directors. You don't automatically become a director. You have to work your way up. I just wanted, as we go to each person, we can clarify what degree did you start with? Maybe you needed to get a second degree later, you realized, to advance, and then what type of hands-on work or practical work got you into your current role today. Does that make sense? And well, we can start with Ms. Dobris again.
Okay. Well, actually I got my bachelor's degree in journalism. I came from a different area, and back, when I was in high school, I didn't know what I wanted to do. Somebody told me, why don't you go into fashion? And I said, okay. So I went to a 2-year school to get an associate's degree. It was called Laboratory Institute of Merchandising. I got an associate's degree in fashion. I said, I definitely don't want to do this. I don't like this field. So I said, I'm going to go and get my bachelor's degree. So I went to Baruch. I went to Baruch College. I lost 1 year of credits from transferring, but I said I'm still going to do it anyway. I I went there, I started off in international marketing, and then I finally ended up with journalism. And then after I graduated, I worked in public relations, in two different kinds of public relations. The first was sports marketing, the other one was travel. And then I worked for travel, wholesale travel. Then I worked for, as an assistant to the boss of a temporary personnel agency. So, I think a lot of you can relate to the fact that sometimes you just don't know what you want to do. And it takes years to kind of sometimes figure out what you want to do. There are some people who are very lucky that from the time that they're a child, they realize, I wanted to be a teacher, I want to be a fireman. But not everybody feels that way. A lot of people just don't know what they want to do. So sometimes we just sort of evolve, as we get older. And it's very common for people to change their professions several times over the course of their working career, okay? So it's important, that's why I wanted to share that with you, because that has happened to me as well. So by the time I was, in my late 20s, I was, I guess, 29 years old. And I said, I need to do something else with my life. I'm not going to just keep working at this endless, this dead-end job. So I said, what is it that I really want to do? What do I really like? I love psychotherapy. I always was fascinated with it. I wanted to be a psychotherapist. So I said, well, for me, at this age, I thought I was too old, 29. I said, I'm not going to go and get a psychology degree because it'll take me too long to get a doctorate. I said, why don't I just go and become a social worker? And this way, I can work in a variety of different fields. I can be a psychotherapist. So that's what I did. And I went to Fordham. It took me 3 years to get my master's degree. I had 2 internships. I worked full-time. I went to school and had internships all along. It was really hard, but I did it. And so that's where it all started off for me. And it's important. You have to just dedicate it. I knew that I had to get my master's at the very least, because you really cannot. You really can't get the best jobs unless you have at least a master's degree, if you're going to be a social worker. Okay, that being said. So when I finally graduated, I was looking for a job, and you know what it's like when you're looking for a job. It's like they just want someone who has experience. So how do you get experience unless somebody gives you a chance, right? And this is, I'm sure you've all come across a situation as well. So finally, I was lucky enough to get a job filling someone as a temp. Someone was in a nursing home in Manhattan. This woman was going on maternity leave. So they hired me to fill in for her while she was on maternity leave. So that was my first job in a nursing home. I worked there for, I don't know, 6 months. I don't even remember anymore. It wasn't really that long. And then I had to leave there because it was a temp position. The person came back, and then I had to find another job. So of course, the same cycle goes again. You have to get a job. They want someone with experience, and the only experience I had was my little stint at this nursing home. So I went to another nursing home, and that's how it built. So I worked in the other nursing home for a few years, and then I went to a hospital. And then I worked in the hospital for 14 years in Brooklyn. And at the same time, I also worked in home care services. I worked for several different home care agencies. I would go to people's homes and do all that kind of stuff that I could explain to you in more detail. And then from there, I said enough is enough. I want to have a different job, and luckily, it took a long time. It actually took me a full year to find the exact job that I wanted. And luckily, I actually had a job that I could hold on to until I found the right job that was for me. And that's where I got to be where I am today. That was the process.
Again, it's oftentimes all through personal experiences how you get into some kind of field. And in my case, it was being the caregiver together with my sister, for my parents, my father especially, that brought me into the geriatric field as a care manager. Again, also lucky enough to be able to get a job here, and my personal experience. And for a lot of people who take care of their parents, have that experience, they want to continue that in a more personal and professional way. So that's a great way to get into a field through personal experience. The same with my fitness and trainer aspect of the work I do. Again, also I'm a physical person. I run, I do marathons, I work out a lot, and that brought me also to the field of a trainer for the elderly.
You would mention your certification.
About certifications. Yes. The thing is, care manager and a trainer are professions. Everybody can call themselves a care manager or a trainer. It's not a protected profession. It's not a licensed profession like social work. Social workers are licensed. Doctors are licensed. So nurses, nurse practitioners are licensed, not with a care manager, not with a trainer. So to guarantee professionalism and quality of work, you can do a certification. And for the care managers, there's the National Association of Professional Care Managers. You can become a member and you can become certified. That requires that you have a background in either social work, psychology, nursing, those kind of fields. Those are requirements to become a member and a certified member from the National Association. The same with a trainer to guarantee quality in the work. It's good to be certified, and I looked around what is the best certification, and I found the American College of Sports Medicine. I got my certification. So that guarantees professionalism and quality of work that you can advertise with, and that people like to see. I mean, so that is the difference between social work and a care manager, the certification or a license, right?
So for me, it was a little different. I have only ever worked in gerontology. I've only ever worked in geriatric and social services. So I got my bachelor's degree in social work. I do have a BSW. And when you graduate your BSW and you start looking at schools, because you know you need your master's degree, what happened was a lot of the schools said to me, go get some work experience, then apply to our schools. And that was the best advice that I ever received, was to not immediately go from my bachelor's to my master's program, but to get some work experience first. So I spent a few years working in the field, and I worked at 2 different organizations, and I slowly worked my way up. You know, when you graduate with a BSW type degree or a gerontology degree, you're going to be doing, you know, basic, low-level social work type work. But that's okay. That's building the foundation to go where. Today, I'm the associate executive director of a not-for-profit with a $4.5 million budget. So you build up through that. You need to get as many experiences as you can in geriatrics to just solely, you know, I don't do direct care anymore. I'm not a direct care manager, although at any given day, I may end up in the kitchen serving lunch, or mopping a bathroom floor if someone had an accident, or changing someone's Pampers if they had an issue with incontinence. But I deal with management and budget and writing grants and proposals and supervising a staff of 50 people. But at any given day, you don't know what hat you're putting on. So I graduated with my bachelor's degree. I worked for 2 different not-for-profits. And when I was at that second not-for-profit, I went from a walk-in case assistance manager at a walk-in crisis intervention unit to a senior center program person, to a Meals on Wheels coordinator, to an assistant director of a social adult daycare program. And that's when I went and applied to Hunter, 1-year residency program, which is really 2.5 years, and got my master's degree. And from there, continued to build and get different experiences, including going to the government side and spending a few years with the Department for the Aging, which was a great experience also because it taught me what I didn't want to do. And sometimes those life lessons are just as important as finding your passion. And from there, I just continued to move up the chain to where I am today.
training, which is 6 years. It's something that I knew that I liked it, that I could do it, I did it, but when I came here, I wanted to do something different, and also I did what my parents and my family were expecting me to do. And I didn't have any challenge as to that in terms of because I kind of liked it, and also because I was doing it, I guess, family duty. But when I came here, I did a series of jobs, odd jobs. I cleaned apartment. I worked at the New York State Psychiatric Institute as a research assistant, which job that I was for about 8 years, and I did everything from, I started hourly, ended up with a full-time position as a coordinator, because I did translated interviews, I was trained as a sexual interviewer, I coordinated some of the research ventures that they had. And doing that was that I tried to come back to medicine, but when I was starting for my board, somebody told me that there was an open house from Columbia University about being a nurse practitioner that they were targeting Latinos, and that there would be scholarships and so on. So I went to the open house and I liked the possibility, and so it was a matter of applying to the school, which they required from me to pass a test of, it's called TOEFL, or Test of English as a Foreign Language, and taking a writing level class in English, because I never took that class in particular. And they, because of my prior experiences, they convalidated some of the credits. It was not necessarily easy, but they accepted it. And I earned a bachelor's degree in nursing. I went to what they call accelerated program, which is a program for people who already have backgrounds in other professions and they want to go back to school and want to do nursing. So I did that for a year, full-time, a year, 12 months. And then I worked in a nursing home as a nurse, as a floor nurse. And I never liked to work in a hospital per se. I always wanted to provide medical care meant also to decrease the chances of admissions in a hospital. And so my focus has always been outpatient. And at a nursing home also, the same it's not conducted to what I believe what medical care should be. I thought a nursing home was too focused on the medical problems of the person, not on the older person as a person. It's just like a sick person. It's like a long hospital stay. And they do things in a nursing home that are demanded by the guidelines and without any particular consideration into the impact of that as for the person in terms of is it worthwhile? Is it, for example, I was taking care of patients who were bedbound, who were were severely demented, were not actually responsive, but they were taking 5 medications, 4 for the blood pressure, medications for the bones. It doesn't make sense. I mean, someone who is bedbound, who is older, who depends on others. What are the benefits of these treatments? And so I question that. And when you work in a nursing home, it's a work that is tightly regulated. If something happens, there's the accountability comes in, and everybody's afraid, so people do things without thinking. And so I did not pursue to work on a nursing home, and instead went for my master. And I had to do it in both adults and gerontology because in my days, gerontology should be a specialty. In my days, the education was separate. You went to adult health, or eventually you did gerontology. Nowadays, because they need to provide geriatric care to the population that is growing, and because the people who are interested in gerontology or geriatric is so small, they decided to blend the geriatric content adult gerontological nurse practitioner. I don't think that, personally, I don't think that that's the right thing to do, because I think that gerontology is a specialty within adult health and therefore should be separate. And I don't think that people who do not like to work with other people will know better, or who like to do what they're supposed to do, something that they do not want to do. And so, unfortunately, the need to provide informed medical care to people is such that anybody who passes by a nursing school will need to know a little bit of geriatric or gerontology. There's not anymore that the one who wants to specialize to take care of other people will not have that opportunity to do it separate. When I was a student, we were 150, and of those, only 2 were in the gerontological track. For my position right now, I had to earn a bachelor's in science in nursing, double master's in nursing. You have to have a license, an active license as a registered nurse, and a license for your nurse practitioner piece. In my case, it's 2 licenses, one for adult health and the other one for geriatrics. Because we can, as a nurse practitioner, we can prescribe controlled substances like narcotics for pain management. It's good to have a DEA number, and so that's something that is additional to your requirement. Also, you need to have a certification in your field. If you want to work in a reputable institution, you must have a certification from a nationally recognized institution. In my case, I have American Academy of Nurse Practitioners and the American College of Nurse Practitioners too, because there are so many institutions overseeing that. Right now, I work for New York University College of Nursing. My position is funded via HRSA, or Health Resources and Services Administration, which means that I have to provide primary care services to older adults, plus I have to be an educator to nurses. So I have to teach clinical gerontology to nurses. And I work in the field, in the community, part of my job, in part of other parts in an office. I got this job after working for 6 years at New York Presbyterian and the Division of Geriatric Medicine and Aging. In 2010, the Harper Foundation, which funds the most important works when it comes to nursing and gerontology, hosted a contest about the day in the life of a nurse, and my entry was the winner. And so when NYU got the grant, they saw my video, they called me, I was interviewed 3 times, and finally they gave me the position that I currently have. Right now I've been working for 6 months. I work going to NORC in the Lower East Side, providing health promotion to the seniors there, to teaching the students how to provide health promotion talks to seniors, making sure that this gets done, and also in the clinic to teach them how to evaluate older adults and how to interpret diagnostics tests, how to apply the diagnosis to the treatment, and how that will impact, the treatment will impact to the senior, because sometimes the treatment, however correctly it is, for example, that there is a pill for this ailment, sometimes that can be the wrong thing to do, and so we have to be careful.
Okay, I started off, let me what I wanted to do. So I went to Lehman College and I entered the social work program and graduated with my bachelor's degree in social work. Because Lehman College has the advanced standing, because Lehman College is recognized as one of the accredited social work programs, you can then do your advanced standing at certain other higher education universities. So I went on to NYU, did a year, 1 year advanced standing. Okay, take that into consideration when you do your social work program here. That you can do your advanced standing master's degree in 1 year. So I did that. But then I went on to work for child welfare for 12 years. It was a challenging field, but I loved the field. And after 12 years, you start to get a little tired and burnt out when you have to work with teenagers in foster care. So I started working for something else and was introduced to the NORC program. Even though I had no real experience in geriatrics or aging, I was successful in obtaining a job there and as a case manager. And from there I was promoted to a director, because I guess of my work ethics, so you have to have that too, even though you have the degree. I am also, as the director of the NORC program, the requirement is just a licensed master's degree. But I already had a background in clinical social work, so that was an added incentive for me receiving the position. I have to encourage the disciplines because I know, and I'm not sure all the different disciplines you have present, but I think it's so very important that the social workers, the gerontology students, the physical therapy students, it is all connected when you have to work with seniors. We tap into all the different disciplines to work with our seniors. They need a wide range of services, and it starts with social work. It starts, yes, someone is shaking their head, yeah, because they all interact, and we need to collaborate with all the disciplines when you have to service the seniors.
That is hold on to the mic. That is a perfect step to our next question here. And I know each of you have touched upon it, but I thought Ms. Austin just explained that perfectly and raised an important question. While each of you are pursuing your individual degrees and an individual professional role in the future, I think all of our speakers are trying to tell you that in geriatrics and gerontology, you really have to be prepared to know what other people do, be able to work with them, and several of the speakers said wearing different hats at different times, but it also really means being aware of what other people can do in their professional practice so that you can call upon them, work with them, and collaborate with them. So if you could keep the mic, Ms. Austin. That was exactly our next question. We want to really impress upon all of you that while you're preparing to be a social worker or a physician assistant or a nurse or a nurse practitioner, you really have to know what all of these other disciplines and professions can do, including physical therapy, occupational therapy, psychotherapy, social work counselor, pharmacist, et cetera, as well as community organizer, planner, program director. So if you could touch upon, we're going to ask each of you, in your daily work as care manager or program director, how many people are you really interacting with on a regular basis where you need to know how you can work with them?
Okay. At my program, we do have case managers. We have 4 case managers who case manage means that you manage the case for the senior. So whatever that senior needs, you have to ensure that that service is being provided. We do have a healthcare practitioner. We have a VNS nurse who comes in. So the health aspect of the senior is also taken care of or looked at. So you have to do a We are funded by the Department for the Aging, and the big issue now is that when we consider working with the client, you consider the health benefits of that would go towards that client, and they're pushing health and wellness, health and wellness.
That's all we hear, health and wellness.
Because that is important for the senior, for the individual. You're not going to just counsel them on what they should do or where they should go. You got to introduce them to all the other aspects and discipline that will support their healthy living. So it is very important that, you know, in our day-to-day, and as a matter of fact, a couple of years ago, we did have a gerontology intern at my agency. We had physical therapy interns at my agency. And it's something that, I do supervise, and this is another thing that social work students should consider, because I supervise interns from the colleges. And in order for you to supervise the intern, there's another certificate you need, which is called the SIFI. It's Supervision in Field Instruction. So it's a certificate you need to take. So in my role, I do supervise interns from various colleges, including York. So yeah, you have to introduce discipline to these aspects of the discipline. So you introducing them to the health field, the physical therapy, because seniors do need physical therapy, occupational therapy, and we are trying to give them that well-rounded, holistic approach to staying healthy.
Excellent, thank you.
So how do I partner with other disciplines as part of my work, your work? To work in gerontology, you have to interface with other disciplines, because other people have certain needs. To me, my right hand is essentially, it has been social work and occupational therapy, or physical therapy, because the problem is usually a social problem or psychosocial problem, or it is a problem in terms of function. Can the person do this or not do that? And so, especially for frail older adults, the problem is a little medical, and for bigger part, it's probably social, psychosocial, or functional. And so I have to work with social work very closely. And so one of the things that makes us interface, for example, just one example, an 83-year-old woman who is found on the floor, and they bring her a few days later to the clinic. So this 82-year-old woman, she has diabetes, she has hypertension, she has arthritis, and she recently had a fall. So as a nurse practitioner, you have to not only evaluate those conditions, but you have to evaluate the impact. You have to check her vision, you have to check her sensation in her feet because of the diabetes. And so there already goes to the specialties, the ophthalmology and the podiatrist. And also because hypertension and diabetes, you will have to check the heart. And so you have to refer her to a cardiologist eventually. And then there's also the issue of the fall. How is her home environment? How can she use assistive devices like a walker or a walking cane? And so you, as a nurse or as a nurse practitioner, you learn a little bit from all these people, and you do a little bit of their assessment, and then you send this older woman to this specialty with already an idea of what you expect. So, and eventually it's also you have to deal with the family. Is the family is around or not around? Does this woman has a emergency system to get help, and she's fall again? Or did she already have something? Because older people have certain habits, and there's a way of catching their emergencies. And where is the family involved or not involved? And what can we do to transition this patient back to her home? Because ultimately what you want is that she goes back to her usual environment. And so you have services, you have to deal with the physical therapy at home also. You have to deal with who's going to install in their apartment the stuff she needs to be safe for her to take a shower. And at the end, so you need to coordinate those things. So you have to bear in mind when you call and if the things get done. Okay.
So everyone's saying everything very eloquently, and I'm going to really just be real with you, which is that, and they're being real too, but if you don't like to talk, and to have people talking to you all day long, and asking you questions and calling you, then you're in the wrong field. Because there are days I go home, and I don't want to talk to my family. I don't want to hear the sound of my own voice anymore. My throat hurts. Because all day long, you're talking, and you're talking to many different people. In one moment, I'm talking to a food vendor, finding where my food delivery is. The next minute, I'm talking to a caregiver to find out why mom hasn't been to program in a week. And the next breath, I'm talking to an employee who no show, no call to work. In the next breath, I'm talking to someone because they wandered down the hall and they just want to talk. And they want to tell me about the weather outside, and we're having a conversation about that. And as she's sitting across from me telling me about the weather outside, my phone is ringing, and my other line is ringing, and it's the food vendor again saying the milk is going to be late. So if you're not able to keep a lot of balls in the air, and just talk, and keep it all straight, and always have a smile on your face, because even when in my head I'm screaming a lot of 4-letter words, I have a smile on my face and the sweetest voice you can imagine. And then maybe I have to shut my door for 5 minutes and scream to myself. But you have to always be talking. So you just need to be able to interface with everybody. And the bottom line is what I always say to my staff, and this is like the #1 rule of social work, and it really goes across to all spectrums of whether it's physician assistant, is the client comes first. We cease to exist without our clients. And that is the one thing I put into my staff. The word no does not really exist for me. And they roll their eyes and they make jokes about it, but we cease to exist without our clients. We are here to serve. We do not go into this field for the money. We do not go into this field for accolades. We do not go into this field for my fancy, schmancy offices. Because I have roaches and rats.
I've seen your office.
I work in a New York City Housing Authority building on 170th Street. Just up the block. It's not pretty. But we do it because we care. We do it because we love our clients. That's the only reason we show up to work every day. Because let me tell you, the paychecks are not fat. But you need to be able just to interact to 2 hours ago, I was dealing with a major problem with the center, but you wouldn't know it right now. I'm sitting here with a smile on my face talking to you guys. So you just need to be able to always keep everything going and flowing, and you're there to serve. You're just there to help. And you're going to do whatever you can to solve that problem for your client. And so often, we are their lifeline. We are, especially in New York City. You have more shut-ins than you will ever imagine. You will be shocked what you find as you start working with the clients and saying, where's your family, where's your daughter? They're living in railroad apartments sometimes, walk-ups. You can't believe the conditions sometimes our older adults live in. And they manage, and we just want to help them. So if you don't want to talk, then you need to find another profession.
So York students, if you came here as a freshman, York students, you know this as part of general education, are required to take a speech class. I never thought of that as preparation for gerontology. Maybe it is.
The light.
How do you beat that? How do you follow that? I'm sorry. Just end it right there.
It is all about independence, right? People want to stay independent. People want to stay living. They love to stay in their homes, and that's when the care management comes in. But also, that's when the physical part comes in, because independence means also you'll be able to walk, move, and go out, all those kind of things. So far, I've heard most PT mentioned as a part of the physical aspect to help people to stay healthy and strong. to kind of promote a little bit more the fitness aspect, the fitness part of it. I said there's a difference between a trainer and a physical therapist. A physical therapist is a licensed profession and is also a more in the realm of the rehabilitation. If something goes wrong, if someone breaks a hip or falls or hurt themselves, then the physical therapy does rehab. Also the payment then goes oftentimes through Medicare or insurance. So, but of course there is a certain amount of time and sessions provided.
Training, particularly with baby boomers, how do you prepare for yourselves or future geriatric care managers working the idea of a business model where you're trying to attract clients and maintain an income for things that aren't being reimbursed through insurance? What if the demand increases, but you're not sure where the funding is going to come from? Maybe that's, I'm saying, who are your clients, basically? Who do you anticipate your clients will be? Is that clear? Yeah. If the demand goes up, you all should have a great income, but who are we really talking about in terms of your patients and your clients?
Okay. Well, in answer to Dr. Cassidy's question, the sad truth is that based on the information that has been provided thus far, with the severe reduction of programs and closing of programs and social service case management agencies, people are going to have to pay. Bottom line, there are some people, they can't afford it. This is life. Some people can afford it, some people can't. So with what I do, people have to pay privately for what I do. Okay, and not everybody will be able to afford it, but that's the way it is. So that's who I see. I see a lot more private pay clients coming into my area because they can't get the services as quickly as they may need to in the social service agencies. I try to, sometimes I try to help and I make referrals to social service agencies, but the clients don't want to wait. They need their services sooner. They want it now. They want personalized service. They want someone to come and hold their hand, but they have to pay. They have to pay for it. That's the bottom line.
Okay, I want to add a little bit to that. That's the truth. So if you go for a career in the geriatric care management, you either go at a corporation. So I work per diem at SeniorBridge, a big corporation, as a care manager. So you don't have to worry about referrals or your clients. You get your clients. That's what the corporation, the company does.
They would assign clients to you.
Yes, but if you are a sole practitioner, so as a care manager, about 80% or 85% are sole practitioners. They work for themselves. So you have to be competitive. You have to be able to set up a business. So you have to be able to compete, make decisions, work for yourself, be available 7 days a week for 24 hours. So in that case, you have to question yourself: do I have the entrepreneurial material to set up a business and run a business by myself? You can hook up with a partner. You can do it with more people together, but that's different. So you have a little bit more support with each other. But it is a field that indeed you have the clients have to pay, and not everybody can pay. New York has a population poor but also very rich. So there is diversity, and there is still enough work for sole practitioners. In my field, also the fitness, the trainer field, the exercise field. I have clients who are very rich, so they pay a lot. I have clients who are very poor, so they pay less. So I work with a sliding scale, and I go also out to community centers where people can go, seniors can go for $5 or for free and do exercise. So that's my contribution to kind of a diversity of reaching clients with different income. But again, there should be some kind of support and financial support for this kind of field, I believe. But unfortunately, that's not the case. You have a question.
Now, I have a quick,
Oh.
to this, from the senior center perspective, do you feel like you have this inadequate staff to address your requirements for health and wellness? No.
Never. There's
Never.
never enough money to do what we do in the not-for-profit sector. There's never enough staff. And the need is always greater than what we can give. Because we're serving those that are the low ends of the spectrum, of the, low income, middle class specs. Someone who can pay for a private care manager like provided over here on this end of the table will not be most likely coming to a senior center for a $1.50 contribution for a hot lunch, which is 1/3 of the required, daily RDA taking it.
Yeah, one thing, in my current position, I have to interface with several NORCs, and so I have the opportunity to see how they are function, how they run, and the reality is that small staff of someone who a receptionist who coordinate activities, for example, a case manager who deals with people that show up with any form. So volunteers. It's basically with a little money, but they have a jar where they put their pennies. They have art and craft to sell things they make in order to have funds for their trips or for certain activities. Basically, people who have families, the reality is that most people do have some relatives that may contribute a little bit. But those NORCs and those senior centers function largely in part because the people who are working there are making hard from their guts in order to make their work. Otherwise, there's nothing there. And some of the seniors that are able to contribute also. This is really, I think it shouldn't be the case. It shouldn't be the norm. It should be the other way around. There should be more money flowing into these activities because the seniors need socialization. When seniors are together, when one of them is not doing well, and you try to address that. For example, now with the hurricanes, at the north where I was, they were there, they were congregating there, looking for stuff, looking for the information, how to apply for FEMA, what to do, desperate, trying to contact families and relatives, having someone of the staff to call their relatives away, and so on. And so if you live nearby one of them, please stop by and see how they run and see if you can contribute with either help or a good box or something once in a while. Thank you.
Okay. At that point, I'm going to end kind of our formal questionnaire here for all of the panelists and turn it over to you to see if you had specific questions. I want to give everyone a round of applause. And you started to kind of anticipate. I was wondering if anyone might be curious how each of these people served the needs of their clients during Hurricane Sandy, but I will wait to see if that comes up. And I'd like to turn it over to you to see if you have questions for our speakers. I saw some hands over here, but no? Oh, on this side I see, yep.
Well, so you have a cross spectrum at the table. So you have like fee for service kind of on this end, not to segregate us, but they're doing fee for service. So who they're serving is kind of the upper middle class to the wealthier older adult. The bottom line is the need is growing. The numbers of aging are growing and growing. And then over here for Sherba and I, we work in the not-for-profit sector. So we charge a voluntary contribution. You can get transportation, breakfast, lunch, case assistance, play bingo, have an exercise class, hang out, watch cable TV, and I don't have to charge you a dime. You can do all these services for free.
So
we are not, it's because we're government funded, it's a voluntary contribution. All our paperwork has to say voluntary contribution. I cannot deny you a meal if you are 60 years of age or over and you're hungry. Even if you may have $1 million in the bank, but if you don't want to give me $1, you can sit down and eat for free, and I'll welcome you.
So how would we help the students understand that? If we always talk about the population is aging and the millions of more people who are going to need services and need care. If it's the other side of the spectrum, help them understand that. So why is there no funding, or why is the funding?
This is what you're watching across the city. Really, you see it going across every spectrum: libraries, hospitals, schools, and education. It's these budget cuts, and what we do every year, I call it the budget dance. And Dr. Cosley's seen a little bit of it with an organization like Council, where we do this advocacy, and we do letter writing campaigns. Every year you will find me on the steps of City Hall with my seniors, with signs. We do press conferences. We visit them at their City Hall offices, and then we visit them here in the community. We go to Councilman Comrie's office. We go to Councilman Will's office. We invite them into our offices. We meet with Congressman Meeks, and we tell them our needs and say, don't forget our seniors. They built this city. Stop cutting. Don't make these cuts on our backs, not on our backs. And the daily what we get back for a meal is $1.35 per meal. $1.35 a meal. Yeah, the minimum is $3.75.
Your costs are going up?
Right. You know, when you go to the grocery store and you go, holy moly, what does this gallon of milk cost? Well, we're facing that same cost as you are, and we are reimbursed $1.35 for a meal that is mandated to be 1/3 of the RDA. That means
recommended daily amount.
Right, you have to have whole wheat products, you have to have milk, a vegetable, a starch.
I think the bottom line is that we as the professionals in the field have to be constantly advocating to our elected officials and government for funding, because the need is there. They are aware of it, but they too are doing the budget dance.
Who do we cut?
So we just have to make them understand that our program is important. We need it. The teachers are there saying the same thing.
I know.
Aging is not sexy. That's what I always say. Aging is not pretty. People don't like to address it. It's like the elephant in the room.
Well, let's keep the questions here.
To answer his question, the demands for people who have training in gerontology is there. The numbers are out there. But also because that has created also sources of opportunities. For example, big companies that have, for example, where I work, New York University, they have a wellness program, right, that is geared towards the staff, faculty, and what have you. So it turns out that because of the staff is also growing old, they need someone who will understand aging.
Interesting. So private sector employee health.
That's private sector in big companies. For example, the insurances, some of the private insurances, they need people who understand gerontology because their customers are older. They need to target these services that they have to an older population that in a way that their cost to them is less. So they need to, it needs to be applied. So the need is there. In terms of the government, it's what it gets tricky, and also because of the economy as it is in the public venue. But the need is there, and as a career opportunity is more of open.
One, and then I'll go to, yep.
I want to ask you, what changes you expect with this happening Obamacare?
Obama healthcare reform.
Well, the Obama healthcare reform, it is expected to increase the number of people who have certain forms of medical insurance, and with that, the numbers of people who need primary care. In the population in general, in terms of all the adults, I'm not so sure, because if you are legally here, you probably have Medicare. And so only people who do have Medicaid is another matter, or who have private insurance is another matter.
The truth is we don't really know yet. Just like those of us who have private insurance, we don't really know what's going to change with the Obamacare. We don't really know what's going to happen in aging and healthcare either right now. There's certain caveats. We do know managed long-term care is changing dramatically as we speak, but a lot of it we just don't know yet. There's a lot that hasn't been released about Obamacare.
They also talk a lot about primary care, but the reality is that people like their special care, and so people like their ophthalmologists, so cardiologists, and so chances are that they will still have the higher salary. Primary care is always underpaid. Gerontology, although unspecialty, is not considered as such. A medical doctor who specializes in older people is a geriatrician, and her salary for that person is not even half of the cardiologist. Okay? So, for example, a cardiologist makes $200,000 or more a year. A geriatrician earns about $140,000. And even though the care delivered by a geriatrician can be more cost effective, it is less glamorous. It's not dramatic. So people are not interested. People want their specialty because they deliver the bells and the whistles. You know, the pacemaker, the defibrillator, when the older person who has is dying, they don't show up to turn it off. And while the person is dying, they're getting shot all the time, and the family want the best for their father. They're out there advocating to get this device, and when they are faced with that, they don't know what to do. They don't know that the person is dying, that they don't know that they chose a device that prolong somebody else's life at the expenses of suffering, perhaps, that may not gonna get them around walking around anymore. But the money goes to the ones who put the device and the cardiologist, not to the geriatrician who have prevented that.
Let me just quickly.
That is not going to change. It's not very special.
I'm sure if you're following, we have 3 more weeks in Congress to figure out whether or not we're going to go over the fiscal cliff. And one of the big issues right now, related to your question about healthcare reform, is the battle over Medicare and Social Security, and whether or not there'll be any cuts in benefits or delays in allocations or increasing age for eligibility. And since you mentioned Medicare, we're waiting to see what happens. But one of the other key features of healthcare reform is asking each state to expand its options for Medicaid coverage and expand state allocations. And several states right now are refusing to honor that part of the Healthcare Reform Act, to create state exchanges.
Right, and they took it to court.
And that was, I don't know if anyone had anticipated that. It started very quietly about a year ago, and now it's growing, where the key feature of healthcare reform is that every state is supposed to provide state subsidized options of health insurance to their citizens. And so it's starting with the governors, and the governors are saying they will refuse to start creating those insurance exchanges. So, I just want to get to more questions from the audience, and then we'll come back to you.
I had a comment more so than a question, and as we're looking at the interdisciplinary team, we cannot look at aging and the baby boomers getting older void of several key factors. One being what? Socioeconomic, right? Because cash is still king. And we can't look at aging void of the whole political arena as well. And I think Stephanie said that we have to be able to talk. We have to, as geriatric care managers, become the voices for our senior citizens. We have to be the ones to go to Albany to advocate, to say we would like more money for, because it's about providing the services in the home, but it's a little bigger than that, and we have to look at everything, globally, as opposed to just what we do in our own specific areas.
I've been to Albany, I've been to City Hall, and I've been to DC doing advocacy. You're always advocating. At a dinner party, at a conference, you're always doing the advocacy. It's on. You can never turn it off.
So I know the hand was up over here, and then I'll come to you next.
How do you, for the ladies that work in the public sector, how do you advocate for your patients in regards to their insurances, like the managed Medicares and Medicaids that they have now, where their hands are one time?
Are they coming to you with those supposed to
They do, I mean, they do. It's a fine line we have to walk, and you might agree. You know, we can't tell them what to choose. It's for us, it's a very fine line we have to walk. We can help educate them, we can explain all the options, but it's very important that we don't make the choice for our clients. We just, you know, present them every option, but we have to always be non-biased at all times. And even though you may personally have a worse experience with Health Plus or, you know, Empire, whatever it may be, we have to take all bias out of what we do. So while we can help educate them, we can contact them, show them the links. Sherba, I don't know if you do it also, so. Well, I don't really either.
That's something that it's very difficult actually, and that's something that the family sometimes should be involved and sometimes they're not.
In the community-based setting, we're dealing with that families also.
And so that's something that is, you know, unfortunately is done by the recipient of entitlement. We come in sometimes when there's a problem. For example, they need a referral for X or Y specialty or service, and that particular plan does not cover it. Sometimes, unfortunately, the only advice that I tell them is that if the HMO is offering them a trinket, beware.
A what?
A trinket.
What are they offering?
They give you everything. They have giveaways, freebies. Best bingo prizes ever is at the HMO.
They give them, you know, $50 a month in a local dwelling.
They'll pay for trips, they'll bring entertainment into the senior centers.
So they're being lured by these companies, and so sometimes they change. So they change the plan entails changing the doctors that they knew for years, and so on. But we cannot tell them other than that.
Maybe you ask.
I do tell them not to.
This, you know, right now there's only, well, we're 3 days away. You have 3 more. Tell your grandparents and aunts and uncles that 3 more days to choose, you know, switch their Medicare plan or their Medicare Part D drug plan. And if they didn't know that, and maybe you need to be the advocate and help them.
Well, a lot of times they come to us because they're bombarded with information.
Yeah.
And we have to help them sort through it and understand which one represents. And it's up to them, you know, at least educate them on what you think might be beneficial to them.
Yeah.
Yeah.
That's about it.
That's good. So.
Sometimes, unfortunately, because we are professional, they expect, some culture expects us to tell them the directives, and we can't.
Oh, like choose a drug plan for them.
Yeah.
And you can't do that. Yes, Professor.
Okay. The topic or the title is Careers in Aging, and I want to thank all the presenters as someone who's a gerontologist and as an occupational therapist and a provider of services. But as someone who teaches gerontology, I think there's another piece to look at this for those students who are gerontology majors. And I think it was said, but I just want to reiterate from my perspective. If
So there may be new fields here in the making.
Yeah, because I also recently had a meeting with two students from Harvard who were looking at the urban development in regards to seniors, to outfitting apartments, you know, so that seniors could be, it would be livable.
Right.
You know? A lot of buildings and a lot of apartments are not suited. They weren't built for seniors, so they don't have all the necessary things. So yes, they are. There are a whole range of, you know, fees that you can look at the senior population, how you can service them.
I think I would completely agree. I think that was an excellent point. If you can think creatively to empathize and understand as someone ages, what would they want? What would you want for yourself growing older to be able to stay independent, to stay in your own home, and then start to build on that and think about it. How might your needs change? All of those, I think, are the growth sectors. So unfortunately, it sounds like we're talking about back to the fee-for-service side, is if you can tap into people's needs, then you're trying to convince them to pay you for meeting those needs. So that's one side of the population. Yes?
First of all, I would like to say I love how this is a diverse panel, like culturally and in terms of the your positions. But I want to know, how can you guys limit abuse to the elderly in your?
Interesting. We haven't neglect abuse. Some of you might.
Yeah. Because again,
are you? You're a mandated reporter.
Yes, we are.
And are you?
We have to. Well, elder abuse.
Well, you started to talk, because I'm saying, was this in terms of your work site?
Yeah, because we are mandated reporters.
Oh, you are? Okay.
Yeah, and within the field, if you come across, it can be financial abuse, it could be physical abuse.
Right.
You know, you have to understand what's going on with the client, and you have to be able to work with that client. If possible, refer them to other agencies who would better serve them. But if the abuse is outrageous, we call it district attorney.
There's an organization called Adult Protective Services, which is a citywide. It's just like Administration for Children's Services. When you hear a child is being abused, the same system is in place for older adults who have any diminished capacity. So it could be someone who suffers from Alzheimer's, just someone who's an elder, someone who suffers from mental illness and who's 50 could be someone who's referred that way. I think we see more than anything a lot of financial abuse, more than anything, and the surprising part to that financial abuse is often it is a family member. It's a loved one, a caregiver, a child, a spouse, a niece, and there are, for example, my agency has a safety program where we deal with those type of abuses. There are programs out there that specifically deal with abuse in the not-for-profit side, the for-profit side, and in the citywide side with administration, Adult Protective Services. So there's places to refer to heal. And you learn over time through your education the signs of abuse and the cues.
As part of our work, we have to screen constantly for elder abuse, and we are trained to certain signs that we can identify the most likely victim of abuse. Unfortunately, sometimes you do everything you're supposed to do, but you cannot disentangle someone who's older from someone who is the only relative that they may have is also the abuser. It's very difficult. It's a very thorny situation, and so we do that. I screen for that, and usually, the job is teamwork, and social workers, psychiatrists are very heavily involved, and ultimately the law.
We are going to wrap this up. I'm going to see if there's a final comment. Please stick around if you have questions for the speakers, and I just wanted to reinforce the importance of signing in. I know our student helpers, I want to thank you so much. We're handing around clipboards where I wanted to get your email addresses. I just wanted to make one quick announcement is for Gero students at York, majors and minors, I've created a Blackboard site. When you go onto for your courses in Blackboard, if you're a major or a minor in gerontology, you have an additional listing that says gerontology, and that allows me to reach all of the students via email, send them announcements, and stay in touch with them for advising and all kinds of other purposes. We would like to expand that to all the students here at York. If you're interested in aging in various departments and capacities, try and broaden your access to the Blackboard site. And I will talk to the computing department about that. So if you didn't see a clipboard yet, make sure we have your email address.
Sorry.
And wait, did you want to finish about the abuse?
No.
No? Okay.
As professional in this, aging field, what does you guys do to, better learn, go with, you said aging is advancing, right? What are you doing to better yourself, be more knowledgeable of what's going on and whatnot?
Like your own professional
development. Yes, yeah.
Oh, yeah, well, for social work, the National Association of Social Workers has continuing education programs all the time. Hunter College of Rochdale Institute has a lot of programs. They have guardianship training. They have all different kinds of training programs available out there.
There's also ASA, American Society on Aging. It's a great organization. They do a great conference every year. I usually attend that. And it's a week long where you get together people all over the country. You get to see other centers, other programs, talk to people how they do it. It's really, and you just take trainings, classes, workshops. We're all always open to learn. No one knows everything.
Yeah, we have to constantly go to training. The Department for Aging requires it. So, we attend trainings and conferences, and every month, not every month anymore. It used to be every month. Probably every 2 months, all the directors get together for meetings, so we fill up with each other.
Thank you.
Well, there's one more question.
I just had a comment.
A comment, okay.
I was going to add to the abuse of that's fine.
You mean add to our efforts to prevent the abuse to older?
Well, add to a different dimension to it because I'm currently volunteering interning at the Department for Aging, and I'm actually analyzing a particular report on different adult abuse cases. And something that's very different with adult abuse cases compared to children. Children, you mostly, determine it's the parents that are abusing the child, but with older adults, it could be almost anybody. It could be a neighbor, it could be someone from the streets, it could be a stranger that's going to the door and just knows that person looking there, because it's financial issues, like she said, with the abuse. It's not only physical abuse, but more importantly, the financial abuse that all adults go through. Which is a lot of things I'm thinking about. So it's just something a lot of people think about abuse. They think about physical abuse right away, but with all adults, a lot of financial abuse that could happen from anyone at any time.
Okay, very good point. Well, I would like to ask you to thank our presenters tonight. I'm so glad this happened.